In precordial leads V1, V2, V3, V4, V5, V6, the amplitude of R wave slowly goes on increasing, right? It becomes little bigger, then bigger, and here it is like that. So amplitude or voltage of R wave slowly increases as you go from right to left on the chest. Why? Because on the left side there is left ventricle, and you know left ventricle has more muscle mass compared to right ventricle. That's why you get bigger voltage, bigger positive voltage in the left precordial leads, right? And you know septum depolarizes from left to right. So let me draw a heart to make it more clear. So let's suppose this is heart and this is SA node. These are the 4 chambers, and this is AV node, and you know from AV node there is right bundle branch, then there is left bundle branch which divides into left posterior fascicle and left anterior fascicles. So this is the septum, right? And this septum depolarizes from left to right. Why septum depolarizes from left to right? This is a common sense. You know left bundle branch is thicker compared to right bundle branch, right? So you know whichever branch is more thicker, that has more voltage, more current. That's why current travels from left to right. As you know, current also follows the gradient. It goes from higher gradient to lower gradient. Since left bundle branch has more current, so it goes from left to right. That's why you will see a small Q wave before this R wave in left precordial leads, like this. Why? Because current is going from left to right. So in these sided leads V5, V6, you will see a small negative blip, that is called Q wave. So when you see these small Q waves in left precordial leads, these can be normal, but when you see Q waves on this side, this is never normal, because you know first of all septum depolarizes and it is going towards right side. So in right side there should be positive deflection, right? It should not be negative deflection. So if you see Q wave in V1, V2, this is never normal, okay? So Q wave in V5, V6 can be normal. So I was talking that R wave slowly, the amplitude or voltage of R wave slowly increases as you go from right to the left, right? And similarly the amplitude of S wave slowly decreases as you go from right to left. Like if you see in the V1 there is a R wave and there is big S wave, right? Similarly if you see in V2, let me draw it here. So here V1 you will see a small R wave and big S wave, like let's say in V2 there is a little bigger R wave and little smaller S wave. Similarly if you go in V3, the R wave increases, amplitude increases, and S wave slightly decreases. If you go in V4, it is like same. So you can see here in V3, V4 it has almost become isoelectric. So the amount of voltage in the positive side and negative side are almost equal. And if you go towards V5, R wave increases and S wave starts decreasing. And if you go to V6, R wave again increases and S wave is like this. So S wave slowly decreases and R wave slowly increases as you go from right to left, right? This is important thing to look for in ECG. This is called R wave progression. You look whether R wave is progressively increasing in voltage or not. If it is not, then it can be pathological. You know in right ventricular hypertrophy there is a bigger R wave in V1, V2. These are right precordial leads, and if there is hypertrophy, there is more muscle mass on the right side, right ventricle, so you will see like big R wave and a small S wave. If you see like this picture in V1 V2, it is abnormal, it suggests right ventricular hypertrophy. Or it can be posterior wall MI as well. In posterior wall MI also you can see like this picture, R to S ratio is more than 1, but there is little ST depression as well, but it is very difficult to differentiate based on ECG alone. You know, ECG is not always 100% sensitive specific. You have to correlate clinically, like if patient has symptoms of cardiac ischemia, and if you see this picture, you have to think that it can be posterior wall MI. So ECG is not diagnostic, you have to correlate ECG finding with clinical picture, and if you have other modalities like echocardiography, you have to correlate it. So never rely fully on ECG, you have to always correlate clinically, and if imaging is available, you can do imaging. So I was talking that in V1 V2, if you see the voltage, positive voltage is more than negative voltage, then that suggests RVH, or it can be posterior wall EMI. But if this voltage on the left precordial leads is greater, like this, so when the voltage in the left precordial lead is greater, in the same magnitude, this S wave is also becomes greater in the right precordial leads. So if you sum up the S wave in V1 and R wave in V6, if it is greater than 35 mm, then that also suggests you LVH. This is one of the criteria for left ventricular hypertrophy. Other criteria of LVH is in AVL lead. In lead AVL, if the voltage, positive voltage is more than 11 mm, then that is also one of the criteria of LVH. Another is R wave in AVL plus S wave in V3. If it is more than 28 mm in men and more than 20 mm in women, that is also one of the criteria of LVH. So I told you three criteria, one is AVL, one is RAVL plus SV3, and this SV1 and RV6. So just remember three criteria. This has high specificity. These criteria have high specificity for diagnosis of LVH, but sensitivity is low. That's why you may miss LVH in ECG, and when you do echocardiography, you might find concentric LVH. We encountered many cases, such cases, when I was doing residency. In ECG, we did not used to see this criteria of LVH, but when we used to send our patients for echocardiography, they used to mention the patient has LVH. So this is about LVH. Now let's talk about RVH. So I told you, if you see R wave greater than S wave more than 1 in V1, that suggests you right ventricular hypertrophy. And this is not the only one thing that you look. You also look for right axis deviation. If there is right axis deviation, that also favors you towards RVH, because as the muscle mass in right ventricle gets increased, so the net vector shifts from the left side to right side. So cardiac axis, the net cardiac axis shifts in right direction. Net cardiac axis is in right direction in right ventricular hypertrophy.